The Washington Manual of Surgery podcast is based on the 9th edition of the best-selling Washington Manual of Surgery.
This podcast is meant to condense key topics from our manual into bite-sized episodes for your convenience. Now, on to this installment of the Washington Manual of Surgery podcast.
Hello, everyone, and welcome to the Washington Manual of Surgery podcast. We bring you everything you need to know about high-yield general surgery topics built for your just-in-time learning. On this episode, we are thrilled to have Dr. Kirby here to review the management of all things burns.
Thank you for inviting me. It's great to be here.
Dr. Kirby is a trauma, acute, and critical care surgeon and the director of the Wound Healing Program at Washington University in St. Louis. My name is Oluseye Oduyale, and I am a general surgery resident here at WashU, and I will be your host for this episode. Today, we're exploring a topic that affects millions globally: burns. We'll guide you through some of the epidemiology, classification, treatment, anticipated outcome of burns, drawing insights from a prestigious resource, the Washington Manual of Surgery.
That's right. It's a pleasure to participate. I want us to understand that burns are not just a subclass of injury. They really represent a traumatic experience where our patients are wounded people and they have to get through their experience with physical and psychological effects that really highlight the complexities of what a burn patient and person goes through. And the WashU Manual is meant to be a summary of many resources that exist. Most of them are available online with excellent material that will complement the WashU Manual as well. And the combined efforts of many professional societies, including the American Burn Association, the American College of Surgeons Committee on Trauma, have really impacted worldwide to improve the care of the burned patient. And I would encourage our listeners to make good use of all of these online resources highlighted in the manual. Thank you.
Yeah, thank you for highlighting the multi-organizational effort that goes into this work. But yes, burns do more than just physical damage. They compromise the skin's functions in fluid retention, thermal regulation, and the infection barrier. And though most initially when I think about thermal injury from flames or hot materials is what burns are, burns may occur from chemical or electrical exposures as well.
That's correct. All good points. Burns are the type of injuries that can occur in a variety of places, both in the home and in the workplace. And as we begin, we should highlight all of the work that many stakeholders have done for prevention. If we think about all the types of injuries that occur in the United States, the burn community and all of its stakeholders, from ABA members to firemen to architects to people that make better design of clothing, have really impacted on preventing this specific kind of injury. And that multidimensional approach has lowered the incidence of large body surface area burns in the United States and worldwide. And I think it's important to recognize that prevention is key, and that multidimensional approach might also bear fruit in other areas of injury prevention.
Yeah, that makes sense. Let's start with a case scenario, Dr. Kirby. We have a 28-year-old chef, Sarah, who was caught in a kitchen fire, sustaining burns to her arms, trunk, and face. She's rushed to the ER. And Dr. Kirby, what are the first things you do or think of when you see a patient like this in the trauma bay?
So my first thought is to compliment our first responders that are rushing her to our emergency room. Many times our police, firemen, and emergency medicine personnel have already started excellent care in the field with great triage and early interventions. And then when they bring them into our trauma area for assessment, we start off with a good timeout where we listen to their pre-hospital report, their SBAR type coverage of what they have found and what they have done and what is the patient experiencing. And then everything flows from that. We begin with a good primary survey assessment, looking at the patient's airway, breathing, circulation deficits, exposure, and their initial fluid requirements so that we can comprehensively assess the patient. In this particular patient, we're concerned that it's a house fire and there may be some airway and breathing components that are the priorities as signaled by the patient's facial burns and the potential for an inhalation injury.
Yeah, perfect. Burn patients are trauma patients, and so we start with all the things from listening to report from our EMS and associated staff and move on to our primary survey. Moving on to our next assessment, after we have ensured an intact airway, hemodynamic stability, and completed our primary survey, what other things do you assess, Dr. Kirby?
So that timeout that we first do leads us through that primary survey. And after assessing and assuring her airway and her breathing, we want to remove all the clothing and focus on stopping any burning processes where the patient's clothing might still have some heat element or a chemical element, like there might be contaminated with gasoline, not in this scenario, but in other scenarios. But stopping that burning process and doing an early assessment of the severity of the burn, and keeping in mind that assessment needs to finish off looking at not just the airway and breathing, but any circulatory impact from the burn, as well as the patient's neurologic status and disability to give us an accurate representation of what might be injured, where they might be feeling pain, and then a complete exposure of the patient where we see their front, their back, at-risk areas that could be missed, armpits, base of the skull, down lower, in between the legs, so that we get a comprehensive primary survey accomplished.
Yeah, with the comprehensive primary survey, one thing that confused me as a junior was truly understanding how to estimate the total body surface area of a burn patient and what clues you look for in assessing the depth of the burns. Could you give us some insight into that as well?
Sure. So you start off with a simple visual inspection and you correlate it with your physical examination, a tactile examination of those burned areas. So very often the patient will lead the way. In a very superficial burn, they may be complaining of pain, sensitivity of the area that you can visually see as red or discolored. And then when you touch that area, even if the skin is intact, they feel that sensation and pain, and it all points to a more superficial burn. If you see that not only is the area changed, either reddened or darkened and is dry, and the patient feels less pain, especially when you examine them, now you're moving toward a more full thickness burn. If the tissue is completely darkened and dry and charred, like an eschar, the patient may be completely anesthetic, and that points to a more complete full thickness burn. And you put all of that together, as well as the rule of nines that you can see in the WASH manual, as well as online on the fly, and a Brown Lundgren chart that will help you map out the body surface area components for those areas that are significantly burned. We typically separate out superficial areas from full thickness areas so that we don't overestimate the fluid requirements for the patient. But that body surface area of significantly burned tissue will then allow you to start estimating along the consensus guidelines their initial fluid responsiveness, as well as that secondary survey, which is a head-to-toe physical examination with tubes and fingers in every orifice, and an ample history, allergies, meds, past medical history, last meal eaten, and I always add on family contacts, and for serious burns, the patient's end-of-life choices as well. Will help you put everything together and will lead you into completing your assessment as part of that secondary survey. So, for example, you not only want to get an estimate of that body surface area burn, but you want to finish off definitively any circulatory problems that might hint toward needing attention to a certain compartment for compartment syndrome or even an eschorotomy.
I see. That's a very comprehensive and holistic review of how to assess a burn patient in the trauma bay. One thing that I tend to underappreciate is the tactile part of the examination. It's not just how the skin or lack thereof looks, but how it feels to you, the assessor, and the patient themselves. Are there any instances, Dr. Kirby, when you would consider consulting other institutions for burn patients?
Yes. Burn patients should be managed in context of where they're presenting and where the burn occurs. And the listener can look at both the WashU manual as well as online at ameriburn.org for the American Burn Association's resource guides for local centers of excellence where burn patients can be referred to. And also, it's recommended that early consultation with the burn center to arrange for not only early care, but further follow-up care is recommended. And the WashU manual highlights the ABA recommendations for when those consultations and referrals should be done. You can see that in our table in the WashU manual.
Yeah, so things to consider for consultation would be, just to summarize, partial thickness burns, more than 10% total body surface area. Any full thickness burn, really, burns that involve the face, hands, feet, genitalia, perineum, or major joints. Inhalation injury, chemical injury, electrical injury, including lightning. Patients with significant pre-existing conditions you should consider. Things that may prolong recovery or affect mortality. Associated significant mechanical trauma. Children or the elderly, and then patient requiring specialized rehabilitation, psychological support, or social services, including neglect or child abuse. Going back to our patient, Sarah, let's say she is currently tachycardic, maintaining her pressures with a map of around 65, setting 90-ish. She has partial thickness burns to her face, her entire right arm and anterior trunk is also partially burned. We find singed nasal hairs, and she has carbonaceous sputum. What would be some of your considerations for initial management?
So Sarah's case is a great one to kind of walk through because it highlights a lot of the most important issues in terms of caring for a burn patient, including she hits all of the requirements and recommendations for consultation with a local specialized burn center, as we previously discussed. Right up front, I'm worried about Sarah's airway and her breathing capacity. And the fact that she has partial thickness burns over her face with singed nasal hair, we want to address any threatened airway. So I want to see how she phonates, how she talks, can she control her secretions? it's worth to mention that singed nasal airway, nostrils, you want to make sure that she's able to breathe through both nostrils together and independently, as sometimes soft rubber lubricated tubing needs to be used to maintain airway patency so the nasal passages don't close off. If she is exhibiting difficulty where she has problems speaking, if I ask her to open her mouth and I see burns going into her oral mucosa, she may be somebody that has to be considered for early controlled intubation, and we would make arrangements for that. Every once in a while, you have to kind of split the difference with a direct examination with fibroendoscopy to see the extent of the burns. I like to make the immediate decision whether or not somebody needs their airway secured with intubation to be a clinical one. But if I do want to do fibroendoscopy to see the extent of the burn, I think it's important to mention that you should preload the endotracheal tube over your scope so that if you see a deeper injury, you can immediately use the scope in a modified Seldinger technique and advance the scope through the cords so that then the ET tube that you've already preloaded over the scope can be pushed over the scope and seated in a safe, proper position. All of these patients should be receiving 100% oxygen by face mask, and all of the patients, especially those that are in an enclosed space like a house fire, should be assessed for carbon monoxide, if not cyanide, exposure and levels of toxicity. And the 100% face mask oxygen, even if the levels are low, should be continued long enough that you account for the washout for carbon monoxide and not weaned based on just the pulse ox, which may be falsely elevated. And the patient may need ongoing supplemental oxygen to wash out that carbon monoxide, which is sometimes difficult since in the modern era, a lot of hospitals have protocols to wean off oxygen based on the pulse ox. While this is being done, we want to secure good IV access with 2 large bore peripheral IVs, and those IVs can be placed even through burnt tissue, and they should be sewn in place so that as the patient is receiving their fluid resuscitation, if there's any tissue compartment swelling, the IVs aren't inadvertently eased out of the lumen of the vein, and then that fluid could be delivered into the subcutaneous tissues, which is why we secure them right from the get-go.
Yeah, when in doubt, airway, breathing, circulation. Other things to consider for patients with initial management of burns in really any critically ill patient, pain control and sedation, the use of a Foley catheter to adequately measure the ins and the outs, an NG tube, especially in the intubated patient, but this may also be necessary for patients in general, given that they may have increased metabolic requirements. Continuous pulse oximetry, tetanus prophylaxis, and then the treatment of associated injuries should not be forgotten. And then you could do your other diagnostic testing, the CVCs, the type and cross, BMP, ABG lactate, and the UA can also be very useful. So a lot of things to consider there, which again speaks to the complexity of burn patients. But staying in this acute phase, in which patients would you suspect carbon monoxide or cyanide toxicity, and how do you approach treating these patients? And we kind of touched on this a little before.
Right. So a closed space fire with an inhalation component makes me think of carbon monoxide and cyanide toxicity. In the modern era, most of the furnishings of a modern household are going to have plastics and cyanide moieties in those artificial fibers and plastics. So I would have a very low threshold to measure levels, carboxyhemoglobin, and even cyanide levels if possible. But then assume that you're going to want to treat that patient for those exposures. So as the resuscitation gets underway with the ABA consensus formula, 2 to 4 cc's per milligram per body surface area burnt, and I should say per kilogram per body surface area burnt, we're going to keep in mind the other exposures and treat them accordingly. For carbon monoxide, the basics are 100% oxygen and enough time to allow that carbon monoxide moiety to dissolve off of the hemoglobin. There are certain cases where we want to add further adjuncts for that, and you've covered them very nicely in the WashU manual in terms of ongoing myocardial ischemia or pregnancy where the fetal hemoglobin is holding on to the carbon monoxide more tightly, as well as patients with severe or worsening neurologic problems from syncope onwards to their current neurologic level to add further adjuncts like hyperbaric oxygen.
Yeah. So in summary, it sounds like our readers should have a high index of suspicion for carbon monoxide and cyanide toxicity. They can be easy to treat, but can cause some serious problems, as you describe, if missed.
We hope you enjoyed this installment of the Washington Manual of Surgery podcast. Stay tuned for part 2 of this episode to learn more about the surgical and psychosocial management of Sarah and her burns. We are Drs. Paul Wise
and Jeff Platnick,
senior editors of the Washington Manual of Surgery. We'd like to thank the residents and faculty of the Department of Surgery at Washington University Medicine, and we'd especially like to thank our associate editors for this edition, Drs. Catherine Caldwell, Ina Chen, Bradley Kushner, Martha Bucky McGilvray, and Jorge Zarate Rodriguez.
We hope that you enjoyed this episode of the Washington Manual of Surgery podcast. For more comprehensive information in a brief outline format, check out the print and digital version of the Washington Manual of Surgery, published by Wolters Kluwer Health and Lippincott Williams & Wilkins. Please search online for the Washington Manual of Surgery 9th edition to purchase your copy of the manual.
To learn more about the educational opportunities available in the Department of Surgery, please search General Surgery Residency at Washington University School of Medicine in St. Louis.